I am Dr. Asim Javed. I'm an interventional cardiologist working at Rawalpindi Institute of Cardiology in Pakistan. This is a series of talks to facilitate learning carotid interventions. So we've got to identify the normal anatomy. This is the aortic arch, and this is the brachiocephalic artery, which then goes on to become the subclavian artery, and this is the right common carotid artery coming off from it. Then this is the left common carotid artery, which has a separate origin from the arch of aorta, and then this is the left subclavian artery, and you can see the vertebral artery arising from it. Now, internal carotid artery. Now, if you look at this common carotid artery, it divides into internal carotid artery and external carotid artery. So the difference between the two is that external carotid artery gives off a lot of branches here, as you can see, and these branches go towards the face. This is the thyroid branch. Now, internal carotid artery, on the other hand, is easy to identify because in the cervical segment, it does not give off any branches. So you can see here that this is common carotid, and then this branch that has no branches coming off from it, this division is the internal carotid artery. Internal carotid artery then has four segments as depicted here with colors: cervical, petrous, cavernous, and supraclinoid. So between these two blue arrows, you can see that this is the cervical segment of the internal carotid artery, this is the straighter segment, and this is the segment which is mainly dealt with during carotid intervention. If it comes to stroke intervention, then we have to go beyond these segments and go into the cerebral circulation. But for carotid intervention, this cervical segment, which is the straighter segment, is what we deal with. So over here you can see that this cervical segment, when it takes a bend, it actually goes into the petrous canal. This is you can see here, that's the petrous bone, and this is the petrous canal. So before this bend, this is the cervical part of the internal carotid artery. Now, why it's important? Because even the distal filter, the distal protection device that we deploy, the distal filter is also preferably deployed in this cervical segment, and we tend to avoid going into the petrous bone or anywhere beyond that. So this is an important segment. And now when you do the angiography, this is the AP view. In the AP view, you can see if you want to engage the neck vessels, they are sort of jumbled up, and it's a little difficult to exactly visualize where the origins are. But if you go slightly into the LAO, you can see 20-30 degrees LAO view. You can see all the neck vessels opening up very nicely, and it's easier to engage. So whenever you want to engage any of the neck vessels, the best is to go into the LAO view, and then you can engage carotid, subclavian, whichever you want to. So what we usually do is that we keep the patient's head straight with chin slightly turned upwards. We remove the pillow from below the head, and then we don't move patient's head for any angulations. We just move the image intensifier in whichever way we want to, but the head remains straight. It's important to visualize the artery from different angles, because you can see here, if you look at this bifurcation, carotid bifurcation, in the AP view, you can see the disease extent here. Look at the LAO view, and now when you go into the RAO view of the same disease, you can see how significant it looks here. So it's important that you see the disease in at least two orthogonal views to look at the exact severity if it's an eccentric plaque. Same thing you can see here. Usually what we do is, my personal practice is I keep the patient's head straight, and then I keep I use a biplane machine, so that's convenience. So one of the planes I keep in RAO 20, and the other plane I go into the lateral left LAO 90 degrees. So it's a true lateral on one side, and it's a RAO 20 on the other side, and usually these two views give me the best view possible to look at the bifurcation and to carry on the intervention. Roadmap is a must. You must use the DSA technology, use a roadmap, or you can call it an overlay, and then do the wiring so that you don't have to do blind wiring or catheter manipulations in the arch. Things become very easy if you use DSA and if you use the overlay or road mapping technology. Now, there are different anatomical variants. You can have a bovine arch, which is 27% cases. All that happens is that the left common carotid artery, instead of originating from the aortic arch, it also originates from the brachiocephalic artery. So that's a bovine arch. And if you see a bovine arch on the CT angiogram before you go in, then you need to think if you want to come femoral or you want to come from the subclavian approach, from the arm approach, which would be easier for you. There can be other anatomical challenges. Common carotid artery, you can see all of these shapes are possible. Internal carotid artery, even this loop is possible. This kink is possible. So you have to keep these anatomies or challenges in mind because you have to deal with them. Now, again, what's important to know is the type of aortic arch. So if you draw a line right below where these three neck vessels are meeting, and the second line right here at the level of this, at the lower level of this arch. Now, if the origin of the brachiocephalic is above this line, that's a type 1. If it is between these two lines, that's a type 2. And if it is at or below this lower line, that's a type 3 aortic arch, and this would be the most difficult to engage, and you've got dedicated catheters to do that, or you need to come from the radial or brachial approach to engage into the carotid. Now, dedicated catheters are available. One is a VTEC or VTK. Then the commonest use is SIM. My personal practice is SIM catheter. SIM2 is the commonest shape that I use. Then you've also got an implant, you've got JB curve, you've got H1. So all of these can be used. So for SIM catheter, it comes in this shape. Sizes are SIM 1, 2 and 3. The commonest I use is SIM 2. But once it goes into the body, it becomes straight and you need to bring it back into this shape. So all you have to do is take an 035 wire into the ascending aorta, take your wire, make a loop like this, bring your catheter on top of it, and then when the catheter reaches this point, you can remove your wire and the catheter will take its shape. The other way to do it is, if your wire goes into the subclavian artery, left subclavian artery, no problem. Follow it with your SIM catheter. Once it reaches this level, then you bring your wire down into the descending aorta, keep your wire here, and now all you have to do is push the catheter. Once you push the catheter with the wire here, the catheter is going to prolapse back like this and it will automatically take the shape. Now you can twist and give it any direction that you want to. So these are two ways of shaping the SIM catheter. You can see the same thing here. That's an 035 wire that you can see here, and the SIM catheter is being pushed onto the wire, and there you go, it's pushed up, and now the wire can be removed. And now by pulling up, just like as you do in coronary implants catheter, by pulling up the catheter goes forward, and if you want to remove it by pushing, the catheter will prolapse into the aorta.
Local anesthesia is given. We usually do the femoral puncture under fluoroscopic guidance. So after injection, we see where the level of needle is as compared to the femoral head. If the level is fine, then at the same point we go in with the puncture needle and wire through the needle, and then without removing the needle, we again do fluoroscopic guidance in EP view to see the height of puncture where the wire is exiting the needle. Then we put in the 6 French femoral sheath and we do a groin check with this contrast injection to see the height of puncture and relationship to the bifurcation, femoral bifurcation. So this is 5 French SIM2 diagnostic catheter, and we shape it up in the ascending aorta or in the subclavian artery like this. So in the ascending aorta, this is how you shape it up. You loop the wire, and then on the loop wire, you just take the catheter up. In LL projection, you do engagement of all the neck vessels. So here the brachiocephalic artery is engaged in the LL projection, and SIM is usually pulled back and it goes up, and to bring it down, you have to push it forward. So then for both carotids, we remove the pillow under the neck, and in RU 30 and LU 90, we take projections for both the carotids. So this is for the right carotid. For disengagement, we again push the catheter, bring it down in ascending aorta, and then again on pulling it up, it has gone into the left common carotid, and the same projections RU 30 and LU 90 for the carotid
Now, if you want to come from the radial or the brachial axis, it's the same thing to engage the right. We shape them in the ascending aorta, and then while pulling it up, it automatically goes into the right common carotid artery. It's not difficult to engage from the arm approach as well. Now this is the telescopic technique, which is also called railroading. You take a diagnostic catheter, longer length, and on top of it, you have the sheath. And once the diagnostic catheter has engaged into the carotid, you just slide your sheath on top of the diagnostic catheter and it will go up. Now, at times, bovine arches are difficult to engage from the femoral approach. You go in, but the problem is that whenever you try to take your wire up, it prolapses. So this is one of those cases where it was difficult to do with an 035 wire. The catheter would always prolapse. So we used a BMW wire, and we thought 1, 2, 3 wires might give us this required support, and we may be able to take the diagnostic catheter up, after which we will change it to an implant super stiff wire, and then we will be able to take our guide catheter up. So this is an effort that you can see going on. Two BMW wires are there, but the moment SIM was advanced, it sort of was about to prolapse. So we took it slightly up, we removed the wires, but the catheter came back. Now this is an 035 wire that's again taken up there, and SIM is being removed, but it did not work. Now, another thing that I could have tried at that time was, instead of implants, if I had changed on over the wire to a multi-purpose 5 French catheter, it might have gone up. But in any case, we switched to the radial or brachial approach. This is the same catheter from the brachial approach, and this is the shape that it made while coming into the bovine arch. And now this is in the left subclavian artery, left carotid artery. Again, it was difficult to take it up any further, so we are trying to do the same thing again. We've taken the BMW wires up. So multiple BMW wires gone up, and over them the SIM catheter has been advanced over these two wires. The effort is to take it higher so that we can take an implant super stiff wire in, and then over that we take the guide catheter in. So now the BMW wires have been removed. Now this is an 035 260 centimeter wire that is up there, and then we are removing the SIM. In this case, we've not taken an implant super stiff wire so far. This is an 035 wire, and that's the destination sheath coming on top of it. And luckily the sheath slides through, so we didn't require an implant super stiff support here. And now once you've got the access into the carotid, then the problem is solved, and you can deal with whatever intervention you want with stroke or carotid. Now, maximum atherosclerotic disease is in the descending thoracic aorta. Look at this disease extent here. So you've always got to be careful that the risk of catheter-related emboli is maximum here. So you should always advance your catheter with a wire ahead of it. So radial and brachial access are also being used for carotid artery stenting. They're feasible and safe. It's an easy access in bovine arch or type 3 aortic arch, allows early patient mobilization, eliminates excess site bleeding complications, and reduces the risk of aortic embolization. Now this is a picture just to show you 5 French shuttle sheath from the ulnar approach, right distal access, radial access, again 5 French shuttle sheath. But what is important is that you should always take a picture of radial or ulnar artery to look at the size, anatomy, and treat the spasm if that's present. Another option could be to use sheathless 7 or 7.5 French coronary guide catheters. They can also be used for carotid intervention. You can even take these catheters, coronary guide catheters, in with the BAT technique, that's the balloon assisted technique. So carotid artery stenting with proximal embolic protection via transradial transbrachial approach. There are a lot of literature that is now there, and that has shown the feasibility of this approach. Another approach in bailout strategies could be a transcervical or common carotid puncture technique. It's easy and fast, but what's important here to understand is that if you want to do a direct carotid puncture, the best thing is to intubate the patient and put the patient on ventilator before you do that. Because if you do the carotid puncture, one, the patient might be moving his neck, and that may make things difficult for you. The other thing would be that if there is a carotid hematoma that develops and it compresses on the airways, then it might become difficult to intubate that patient later on. So the best is intubate him first. The neck will be now static, he won't be moving his head, and the airway is protected. And now you go in and do the carotid puncture. Use a 6 French sheath, don't go beyond 6 French. And The risk of hematoma, that is something that you need to be careful about. So you can do it under ultrasound guidance, or you can do it under fluoroscopic guidance if you already have a radial or a femoral sheath in, and you can take a road map or an overlay map, and over that, under fluoroscopic guidance, you can directly puncture it. So I prefer to use micropuncture kit initially to puncture it. So diagrammatic representation is that you take a needle, you take the wire in, and then you try, especially if you want to do a stroke intervention, then you need to go into the internal carotid artery. So the best would be that you take your wire and try to redirect it into the internal carotid artery, and then you take you upgrade it to a 6 French sheath. So that's a case that we did. This was actually a stroke intervention of a father of our nurse, in whom radial and femoral approaches all failed. It was a difficult, challenging anatomy. So we went in with a direct carotid artery puncture. So that's an overlay where you can see the needle puncture is being done under fluoroscopic guidance. The wire is being extended, and then that's a micropuncture kit that is being inserted. And then once the micropuncture sheath is in, then we take a check injection from the sheath to make sure that we are at the right place. So this is the internal carotid artery because we were doing a stroke intervention. Then we upgrade it to a 6 French, with an 035 wire in. We take the 6 French. This is a long sheath in. This is 90 centimeter sheath which is coming in. So that's another challenging part, that you have to have somebody holding the sheath close to the neck, because very little part of the sheath is actually in, and remaining long part is hanging over the body through which you will be doing the intervention. So somebody has to make sure that the sheath does not come out. The small sheaths, the access sheaths that we use, the problem is you can't connect a Y connector with them, and it's difficult to take equipment through those 6 French sheaths, the soft equipments. So you need something with which you can have a Y connector connected. So it is this. In this case, we are using a Fubuki sheath, 6 French, 90 centimeter long. And then we went up and we did the stroke intervention. This is the MCA that was blocked here, and we recanalized the MCA. And then we did just manual compression over the carotid, and the puncture healed. Now this is a 80 years old female, hypertensive diabetic, 5 hours history of right-sided hemiplegia, NIHSS was 16, so high stroke scale, and pre-stroke MRS was 0, so she was perfectly mobile and in independent state before the stroke happened. There was no bleed on the brain, and the CT angiogram showed critical ostial left internal carotid artery. There was no MCA or ACA occlusion, so our target was ostial left internal carotid artery. At the same time, her ECG also showed inferior STEMI with ejection fraction of 45%. So, which organ to salvage first, brain or heart? Mechanical thrombectomy versus primary PCI. Should we thrombolize this patient, but she has a stroke? IV heparin, can we give her? Antiplatelet? These are all questions that when we come on to the stroke intervention topic, we will discuss these questions. In any case, in this patient, you can see here we are trying to go from the femoral approach. It was a bovine arch again. So you can see that we're trying to do the telescopic technique also, but the angle is such that everything would just prolapse from the femoral approach. So we went in from the brachial approach. In this case, you can see the wire going up. That's a diagnostic catheter that is up, and that's a 6 by 90 centimeter Fubuki sheath that's following. It could not go up. Then we tried the multiple angioplasty wires technique. It could not help us. And then we went on to use a angioplasty wire, and we took a balloon on top of it, inflated the balloon to anchor it, and take the diagnostic catheter up with that sport, but even that failed. So then time is of essence in stroke intervention. So we went in with direct micropuncture. This is the direct micropuncture kit. Direct carotid puncture being done under fluoroscopic guidance. Wire is taken here, And then that's the critical disease that you can see here in the internal carotid artery. You can see that we've taken a check injection from the sheath, and now we're going to upgrade it to our uh, this is, I think, a Fubuki sheet that we've taken, and then that's a the balloon dilatation that we've done, and after balloon dilatation we deployed the carotid stent, and that's a post dilatation that is being done here, and then that's the final result. And you can see here that both MCA and ACA have been they are all patent. So a lot of literature that is there. This is a study from Dr. Adnan Siddiqui and group showing the safety and advantages of using direct carotid puncture during stroke intervention. In any case, in this patient, then we went on to her primary PCI, no heparin on board because of the stroke, and we used the same technology of continuous saline flush through the catheters to avoid clot formation. So we pre-dilated and we've stented this patient. And this patient also had, and when we removed the brachial sheath, unfortunately, there was no backflow, there was no bleeding from the arm. So we had our cardiac surgeon available who did Fogarty embolectomy, and the clot came out. And that's the saturation of the patient after procedure. You can see here of the same hand, it's 95% saturation. And that's the
क्या नाम है
patient.
नाम दसो हाँ वक्त बानो तबीयत वाले जबरदस्त
So, although patient is pretty old, she's over 80 years of age, but had a good quality of life previously, and now she's gone back to the same independent life as she was before having the stroke. So, time is brain and time is muscle. Uh, Direct carotid puncture is a feasible option in cases of stroke with challenging aortic or carotid anatomy. CT angio is very important because you can do a lot of things. You can plan your whole carotid intervention or angiography on CT angio. Look at the aortic arch, look at the calcifications, ulcerations, atherosclerosis. Is it type 1 arch, 2, 3, 4? Look at the carotid anatomy. Is it bovine, elongated, kink, loops? What do you have to deal with? Then decide your access depending on the anatomy. Should you go femoral, brachial, radial, or direct carotid? But direct carotid, remember, is a bailout strategy. Then cerebral angio pre-procedure is a must. Once you've taken the patient onto the table, you must do cerebral angiogram after your carotid angiogram and before you do any intervention, because you have to do cerebral angio before procedure, then do a cerebral angio after the procedure, and you have to compare the two to see and make sure you've not lost any of the cerebral arteries and the patient has not had a procedural stroke. And DSA is a must. You must do DSA for all peripheral and carotids and strokes. You must do DSA and use road mapping technology.